Good morning. Committee will come to order. This morning, the committee will hold an open hearing on the fiscal year 2017 budget request for the Defense Health Program. I can't imagine anything more important than this to the men and women who serve us so bravely and so proudly. I'd like to welcome the Director of the Defense Health Agency, Vice Admiral Raquel Bono. Welcome. Who was named Director last fall. Admiral Bono, this is your first time testifying before our committee. We're looking forward to hearing how the relatively new Defense Health Agency is operating under your leadership. I'd also like to welcome three Service Surgeon Generals, Lieutenant General Nadja West of the Army, welcome, Vice Admiral Clinton Faison the third of the Navy, and Lieutenant General Mark Ediger, is it Ediger? Ediger, excuse me, I apologize, from the Air Force. All three of you are joining us for the first time, which will provide us with a fresh perspective on how the services are managing the resources of the military health system and how the Army, Navy, and Air Force medical needs and the Army, Air Force, and Navy's medical needs at home and abroad. Our nation's ability to respond to global emergencies is impacted greatly by our military's medical readiness. We must ensure that our soldiers, sailors, Marines, and airmen have access to top quality medical care, including education and prevention programs, which will allow them to be ready to fight. At the same time, we must also provide their families the peace of mind that they are cared for while their loved ones are protecting our country. The committee would like to congratulate all of our services for the remarkable improvement in the survival rate of our troops on the battlefield. Your commitment to medical care in theater, as well as research and treatment back home, has substantially improved the chances that our warfighters will actually get better. And many live as a result of the extraordinary things that are done by trauma surgeons and others among you. The committee also supports a robust funding level for the Defense Health Program to meet the commitment to provide the very best medical care to the servicemen and women who defend our country on a daily basis. We're particularly interested to hear what you have been doing for women in uniform, as they now make up over 15% of active duty members. Of course, today's conflicts produce invisible wounds. We look forward to hearing about recent efforts to address suicide prevention, post-traumatic stress syndrome, traumatic brain injury, and mental health issues in general. However, as has been the case for the last decade, the Department faces a challenge with the growing cost and long-term sustainability of the military health system. The fiscal year 2017 budget request is approximately $48.8 billion, nearly 10% of the entire defense budget. And once again, this budget request assumes savings associated with several TRICARE programs proposals that must be approved by Congress that have been rejected over the last several years. We're interested to hear how your current proposal has been improved from previous budgets to obtain the needed support of Congress. The committee also remains keenly interested in the progress on electronic medical records, health records, and the level of interoperability between the Departments of Defense and the Department of Veterans Affairs. Last year, DoD awarded a $4.3 billion contract to improve interoperability, but I want to be clear, this committee considers interoperability between the departments a top priority and is exceedingly frustrated with the lack of progress after several years and the expenditure of several billions of taxpayers' dollars, both on the DoD and VA side of the issue. Again, the committee thanks you for appearing before the committee to discuss these important programs and others. We look forward to your testimony and to an informative question and answer session on other topics, including congressionally directed medical research, which we're heavily invested in, some very important investments, and the health effects of potential contamination at various installations domestically and around the world that affect the health of those that serve our country. Before we hear your testimony, I'd like to turn to my good friend, Ranking Member Peter Fiskowski, for any comments he may wish to make.
I welcome the witnesses as well. Thank the chairman for holding the hearing, and do associate myself very strongly with his remarks about interoperability. It's my understanding each of you are testifying before us today for the first time. We've been working on this issue for 17 years. We won World War II in 4 years. And I'm amazed we're still talking about this. So I absolutely, categorically share the chairman's frustration and would hope somebody hits the gas. My understanding is we're going to continue to make progress through the first part of the next decade, in which I think that's totally unacceptable. But again, thank you for being here.
Thank you, Mr. Wiskoski. Admiral Bono, Director of the Defense Health Agency, you're our first witness this morning. Welcome aboard.
Thank you, sir.
And your full remarks will be put in the record, but anything you'd like to say to us, please proceed. Thank you.
Thank you, sir. Chairman Frelinghuysen, Ranking Member Wiskoski, and members of the subcommittee, thank you for the opportunity to appear here today. I'm pleased to represent the Defense Health Agency and discuss the proposed 2017 budget and priorities for the military health system. The budget we have presented is fully aligned with our enduring commitments around the globe and with the strategic objectives of the department. As the Director of the Defense Health Agency, my primary goals include providing value-added support to the military services as required to accomplish their missions, developing our capabilities as a combat support agency, and optimizing the internal operations of the agency. The MHS has fully embraced an enterprise management approach to our health systems operations. The DHA and the service medical departments have developed shared strategies, enterprise support activities, and leadership development programs that benefit the system as a whole. As a part of the DHA's effort to optimize our operations, we are implementing a common cost accounting methodology throughout the MHS to improve accountability and transparency to the department, the services, Congress, and the public, with improved insight into how resources are allocated in support of our mission. For fiscal year 2017, DoD is requesting $33.5 billion for the Defense Health Program, representing a 1.5% increase from last year's budget request. Almost $25 billion, or 78% of our request, directly supports patient care, delivered either in our military hospitals and clinics or in the private sector. Congress has granted the Department carryover authority each year, which has provided much-needed flexibility to manage issues that emerge during the year of budget execution. Carryover authority allows DoD to maintain better funding flows to minimize disruption of health care services to our beneficiaries. That authority has been extremely helpful to the Department, and we request that it be continued in FY17. We have a number of important priorities for fiscal year 2017. Last August, the Department awarded a multi-billion-dollar contract for a new electronic health record. Our decision to pursue a commercial, off-the-shelf product provides DoD with a system that supports our readiness mission, accelerates our journey to high reliability, allowing ongoing private sector innovation to be incorporated into future releases, and support our interoperability objectives in sharing information with both the VA and with private sector providers. We will begin our rollout in the Pacific Northwest early in the new fiscal year. Our FY17 budget also proposes to modernize the TRICARE program. Our modernization plan raises customer service performance levels, further expands choice, helps direct patients to the highest quality of care, and continues to offer value at an out-of-pocket cost to our people that is lower than virtually any health plan in the country. Although costs have stabilized in recent years through both management actions on the part of the Department and a general slowdown in U.S. healthcare inflation, we are beginning to see medical inflation rise, particularly in the area of prescription drug prices. We are monitoring our spending closely and taking action to manage this growth internally. The FY 2017 budget represents a balanced, comprehensive package of reforms that are directly aligned with our responsibilities. We look forward to working with you over the coming months to further refine and articulate our objectives in a manner that improves value for everyone. The MHS continues to serve as a unique and indispensable national security asset. The DHA is now an integral and integrated part of the MHS, and we are proud to contribute to the modernization of this system through joint action. I am honored to represent the men and women of the Defense Health Agency, and I look forward to answering any questions you may have. Thank you.
Thank you, Admiral Bono. General West, Surgeon General of the United States Army, welcome.
Thank you. Good morning. Chairman Frelinghuysen, Ranking Member Veslosky, and distinguished members of the subcommittee, thank you very much for this opportunity to appear before you to discuss Army medicine and to highlight the important work our soldiers and our DA civilians perform daily in support of our Army and our nation. First, on behalf of the dedicated professionals within Army medicine, I would like to extend our appreciation to Congress and the subcommittee for your continued support for all we do, and we hope you're proud of our efforts. I would like to also recognize the 186,000 of American sons and daughters who are either deployed or forward stationed in over 140 countries around the world. They remain foremost in my mind because our primary duty is to make sure that we support our warfighter. Since 1775, we have remained one team with one purpose, and that's conserving the fighting force. To accomplish this, Army medicine as a total force consists of a committed team of over 150,000 professionals who provide a continuum of integrated health services, and that's in research, training, education, and all of those benefits and all of those capabilities that no other healthcare organization in the world can provide. Army medicine, combined with our Navy and our Air Force colleagues, comprise a joint medical force without peer. As the Army is foundational to the joint force, Army medicine is foundational to the Joint Health Services enterprise. And for the past 14 years, we have supported joint campaigns in Afghanistan and Iraq, and we've responded to natural disasters and have taken decisive actions during contingencies such as the U.S. government response to the West African Ebola crisis. In this, Army medicine continues to prove that we are the nation's premier expeditionary medical force meeting the challenges of a complex world. And we remain globally engaged, regionally aligned, and surge-ready to face the ever-changing challenges of tomorrow. So Army medicine's first priority, readiness and health, is a direct reflection of my chief, General Milley's #1 priority, and that's readiness. As he always states, readiness is #1 and there is no other #1. We see readiness as, and health closely coupled as our Army derives its power from the collective strength of our soldiers. So our soldiers are our most prized and effective weapon system, and a soldier's health is an essential component of his or her readiness. So while we focus on our readiness mission, we must also ensure that we provide all those entrusted to our care with access to high quality and safe health care. And while we have improved access by 21% since 2014, we still are not fully meeting the expectations of our beneficiaries. So accordingly, we continue to diligently work to improve our access. Army medicine also continues to lead trauma research, which is driving changes in civilian medical practice as well. We recently obtained FDA clearance of the first-of-a-kind endovascular device for hemorrhage control called the Reboa, which we're very proud of, and that's literally an intravascular mechanism to tamponade bleeding from the aorta. So very, very, very good advance in that hemorrhage control arena. We're also conducting groundbreaking infectious disease research to combat Ebola, malaria, HIV, and Zika virus, and other infectious disease threats that have global significance. My next priority, force development, is designed to prepare our Army medicine better for the challenges of tomorrow. The price for the so-called arrogance of the present, meaning that we don't recognize the need to be prepared at all times, is very high indeed. I only need reference, as my chief does a lot, Task Force Smith, to evoke the images of soldiers paying the price in blood for a lack of readiness for an unknown future. My commitment to our nation, our Army, and to Congress today is that Army medicine will never be caught unready, unprepared for tomorrow's challenges. Taking care of our soldiers and their families and our DA civilians and our retired soldiers for life is integral to all that we do, and we continue to take care of them. So Army medicine will continue to stand as a unique organization that has the versatility, the agility, and the scale, and the ability to adapt to the challenges that arise at home and abroad. And as you know, the events of the world today, that is an extremely important capability and an attribute for us to have. Our FY17 budget request provides adequate funding to support the essential elements of my 4 priorities, and we stand ready. So our nation's mothers and daughters must know that when their sons and daughters are ill or injured, that we're here and that we're ready, and that we're here to support them. So our willingness and our ability to support that is a sacred trust, and I take it very seriously. We can never and we will never be in doubt that we will be ready to take care of our service members in harm's way. So I thank Congress for your continued support and of our Army and our soldiers, and I look forward to your questions.
Thank you, General. Admiral Faison, welcome.
Thank you, sir. Chairman Frelinghuysen, Ranking Member Visklosky, distinguished members of the committee, it is my honor to represent the men and women of Navy medicine, 63,000 dedicated professionals who every day honor the trust placed in our hands in caring for those who have sacrificed to defend our freedom. I can report to you that your Navy medicine team is operating forward today and supporting the Navy Marine Corps mandate to be where it matters, when it matters, and ready to respond in time of crisis. We are grateful for your strong and unwavering support of our service members and their families. I'd like to highlight a few important points. First, military readiness is our mission. Navy medicine protects, promotes, and restores the health of sailors and Marines around the world, at home or deployed, and in all warfare domains. In an increasingly complex world, as our Navy and Marine Corps stands watch and stands ready to defend our national interests around the globe, Navy medicine stands there as well with them to protect and care for them. As an agile, rapidly deployable medical force, this is what sets us apart from civilian health care. No civilian health plan in the world routinely leaves their families and home on a moment's notice and willingly goes in harm's way to care for those in need. No healthcare plan in the world routinely and daily puts their lives on the line in battle to defend and care for their patients. And no healthcare plan in the world experiences the staffing deployments and turnover we routinely experience and still delivers world-class care. The proof is on the battlefield. Highest combat survival in recorded history. Wounded warriors are alive today who in any previous war would have died of their injuries. Every wounded warrior is testament to the effectiveness of the military health system because every one of them, from point of injury on the battlefield to advanced treatment in our medical centers, were cared for completely and exclusively by the men and women who got their training, their experience, and their preparation in our military treatment facilities. Those facilities are the foundation of battlefield survival, and in my opinion, as a former commander of a combat expeditionary medical facility, a robust military health system is critical to future battlefield survival. Unparalleled combat survival in the longest conflict in our nation's history is proof that a robust military health system that is also our training and surge platforms for our battlefield providers, from corpsman to physician, is essential to combat survival. These three facts are not in dispute. We have the highest combat survival in recorded history. Many wounded warriors are alive today who would have otherwise died of their injuries in any previous conflict. And every wounded warrior received their care from point of injury on the battlefield through their recovery in our medical centers exclusively by the men and women who received their training, clinical experience, and preparation in our military treatment facilities. I should add that investments in medical education and training, along with research and development, are critical to both meeting current and future mission requirements. Our training programs are among the best in the nation, while our global R&D is helping to keep our personnel safe today while countering the threats of tomorrow. This is a system that works and has proven itself on the battlefield time and time again in the thousands of men and women alive today and home with their families and the overall health of the military force and their families. It is also a system that is not perfect. The services are working hard to improve access, care continuity, convenience, and satisfaction that we provide in peacetime. We have made important strides in each of these areas while concurrently increasing enrollment, network recapture, staffing realignments, and other efforts to ensure we provide the clinical experience our staff needs to preserve skills, competencies, and ultimately combat survival in the next conflict. More needs to be done, and none of us underestimates the magnitude of the effort required to improve our peacetime healthcare services. We are committed to continuing the necessary reforms to improve our patient experience and, most importantly, their health. But we must do so without putting at risk the very system which has yielded such unprecedented battlefield survival. We need your help in this effort, and for your tireless support, I thank you for helping us to ensure that those sailors and Marines that stand the watch today and in the future will have the same or better survival than today's wounded warriors have had. In our hands is a sacred trust to do all in our power to return home safely America's sons and daughters who have sacrificed to defend our freedom. I thank you for helping us to honor that trust.
We thank you for your testimony. General Ediger.
Thank you, sir. Chairman Freeling-Heisen, Ranking Member Visklosky, and distinguished members of the subcommittee, thank you for this opportunity to discuss Air Force medicine and our role in the military health system. We fully support the committee's work to ensure our military health system provides those we serve with the best possible care in all environments. We have asked our medical airmen to stretch their already broad range of capabilities to support the Air Force and the Joint Team across the full range of military operations. Their ingenuity and accomplishments drive our continuous efforts to identify gaps and progressively enhance our programs, operational procedures, and overall readiness. Since the early 1990s, critical care aeromedical transport teams have evolved and become the international benchmark for safe ICU-level patient movement. We adapted this capability to create the Tactical Critical Care Evacuation Team to meet combatant command requirements for intra-theater tactical critical care transport. We are now assessing means of enhancing this capability further to include some aspects of trauma stabilization during transport. The Air Force Deployable Hospital is scalable to operational and medical scenarios. We call it the Expeditionary Medical Support Health Response Team. This capability provides emergency care within 1 hour of arrival and surgery with critical care within 6 hours of arrival. Today, we have 683 medical airmen deployed around the world providing medical support to contingency operations, including the trauma team at Craig Joint Theater Hospital in Bagram, Afghanistan, mobile surgical teams at various sites, and aeromedical evacuation teams with critical care capability at a variety of sites. Our success in support of deployed operations is inextricably linked to the care we provide in our hospitals, our clinics, and our many partner institutions, and to ongoing research to advance the technology and treatment capabilities of our deployable teams. Our research programs pursue new knowledge in operational health issues, in trauma care, and in transport environments, focused on new treatment guidelines and new technology to improve outcomes. Such requirements led to the current work to develop the multi-channel negative pressure wound device, now being tested. This device will improve wound care while reducing the logistics footprint and power utilization during transport. Another operationally driven requirement led to the trauma-specific vascular shunt, developed to increase survival, limb salvage, function, and quality of life for those with major extremity wounds. Air Force Aerospace Medicine researchers with the 711th Human Performance Wing at Wright-Patterson Air Force Base in Ohio are developing tools to enhance human performance and safety in employment of new generation combat systems and a broad range of current missions. Strong health systems must continuously improve. Changes to the Air Force performance management process made in coordination with the military health system implemented in 2015 are producing advancements in safety, quality, and timeliness of care. Recent evidence includes the Joint Commission recognition of our hospital at Joint Base Elmendorf-Richardson for outstanding performance on key quality measures. The Keesler Medical Center's top 10% ranking among U.S. hospitals participating in HCAHPS measures of patient perspectives, and favorable system-wide performance against national benchmarks in perinatal outcomes, diabetes management, and well child care. We know our performance as a health system is integral to our readiness, and we remain committed to continual improvement. To ensure the readiness of our medical force, we have evolved to an open and integrated model of clinical practice in which Air Force surgeons and critical care clinicians devote a portion of their practice time to provision of care in partner institutions, such as VA medical centers and Level 1 trauma centers. However, the bedrock of our readiness is the military hospital. The broad scope of care we provide in our hospitals to retired military members and their families and veterans is key to our readiness. The Air Force has 48 sharing agreements with the Veterans Administration, providing the complex cases needed to maintain clinical currency of deployable teams, while enhancing access to care for veterans with the savings to the government. VA referrals to Air Force hospitals grew steadily until we saw a decline in 2015 due to a particular aspect of the Veterans Choice Act. We are concerned about this and working with our VA colleagues and the Department of Defense to map a process to reverse this trend to enable our continued growth in our care to veterans. We would greatly appreciate the support of the committee in this important endeavor. A final point pertains to primary care support for active duty families. Experience has shown that primary medical support to active duty families from our military treatment facilities enhances commanders' efforts to support families under stress and strengthens their resilience. We are strongly committed to the health and resilience of active duty families. I thank the committee for its resolute support and dedication to the welfare of the airmen, soldiers, sailors, Marines, their families, and veterans whom we are honored to serve. Thank you.
On behalf of the committee, we thank you all, the men and women who support you, do remarkable work. And before I yield to Judge Carter, may I say, of course, we know today a horrible tragedy in Brussels, Belgium. And I think most members know we have, what, 700 or 800 military installations around the world, over 225,000 people doing, as we often say, the work of freedom. And the Belgium strike, of course, is a soft target, but we as a committee remain committed to obviously protecting our fighting men and women wherever they are. And it's good to know that whatever the circumstance is, and we would never wish this upon any soldier or airman or seaman, that you're there for them if similar circumstances ever strike them. The remarkable work of that trauma center at Bagram, the things that the airlift that gets people, we used to talk about the golden hour, but in reality, the improvements that have been made that enable people to recover, get back home, and get the best medical treatment. We pay tribute to you, but we're obviously mindful of what happens to civilians in a world where people are still committed to doing unspeakable acts, but we're proud of what you do. Judge Carter, representing the great state of Texas, and I note that the Admiral has some Texas roots. I hope you looked at her biography.
Texas roots are good. Thank you, Mr. Chairman, and thank all of you for what you do to extend the lives and glorify the lives of our warriors. It's amazing what military medical science has been able to accomplish and what we've learned and what you've done so that we can have our loved ones come back. No wars ever met these kind of goals, and congratulations. General West, we had a chance to visit my office, and I have a question for you. As we're all aware, the Army is in the middle of reducing its end strength by 40,000 troops. Of concern to this hearing is the Army's ability to keep and retain practical nursing specialists and combat medics. An argument can be made that the cessation of combat operations in Iraq and the drawing down of combat operations in Afghanistan, that there could or would be a corresponding drop in the need for medical professionals. The Army has spent a considerable amount of time and money training and certifying each of these soldiers, increasing the regenerative problems, and I am certain that these specialties will face inordinate amount of scrutiny during the retention boards given the current environment. What are we doing to ensure that we maintain a robust level of medical professionals and soldiers in the Army given the forced drawdown? Should the Army institute a program to help transition them to medical centers near Army installations so they can continue to treat soldiers?
Sir, thank you for that question, and I appreciate your concerns about Army medicine and military medicine in general to ensure that we have the capabilities that are needed to support our service members all around the globe where they're needed for operations. And I'm concerned as well, sir, to ensure that we've got that capability available. One of the things that we're doing, and first of all, I must also say our senior Army leadership and civilian leadership are very supportive and appreciative and understand the combat multiplier that our medical specialties are. So when we're drawing down the force, they're very keen to not cut too deeply in our medical capabilities. And so we've got 100% support from our senior leadership on that avenue. As far as ensuring that we've got the skills and the capabilities, resident in our force, we are doing, just as you said, sir, having affiliations with our civilian counterparts and having, not as much as I'd like to now, but we're looking at expanding that, similar to what we have at Fort Drum, where we have our providers that actually provide care and take care of our beneficiaries in the civilian hospitals locally. So we're trying to make sure that we leverage that capability as well, working with our VAs and other institutions. We're also making sure that we have the skills not only of our providers but of teams. The nurse anesthetists, the radiology techs, all of those who are part of the team, ensuring that they have opportunities to ensure that their skills are kept up to date. So I'm very concerned as well, sir, and we are working with our sister services as well to ensure that we've got ready capabilities for the future.
Well, I asked this question because, as I think I told you when we talked, the absolute first question I ever got asked as a congressman was about nursing and nursing shortage at all levels in the United States, and that was 14 years ago. In my district, we've created 3 nursing schools in my district. Others have created, and I've helped. But I hate to take, and because of drawdown, lose those trained professionals that are on the ground and saving lives, because we have to, by attrition, we have to reduce the numbers. That's the reason for my question, and I thank you for your answer.
Yes, sir. Thank you.
Thank you, Mr. Chairman.
Mr. Ruppersberger.
Yes, again, thank you for what you do. When we put our men and women in harm's way, we need to take care of them, help them, and do the best we can when they incur injuries and the after effect of those injuries. General West, this question is primarily directed towards you, and it's about extremity injury represents a major threat to the fighting force, not just in terms of number of injuries incurred and their effect on our soldiers, but also in terms of the cost of acute medical and surgical care and cost of long-term disability payments. There's also substantial evidence that long-term outcomes from these injuries are poor in terms of patient satisfaction, physical function, and quality of life. Congress has provided over $300 million since 2009 through the peer-reviewed orthopedic research program to improve treatments for severe limb injuries both in military and civilian populations. Now, to organize these studies and ensure the quality of the research, the DoD awarded grants in 2009 to establish a consortium of trauma centers organized through a coordinating center. Through a competitive process, this led to the creation of the Major Extremity Trauma Research Consortium, METRIC. And this resource has enabled the enrollment of over 5,000 patients in 18 studies funded by DoD, NIH, and others. Thanks to the judicious use of taxpayer resources, the consortium funding has lasted longer than anticipated, but it is expiring. My question, what plans does the DoD have to continue to provide sufficient funding for a consortium and coordinating center to support clinical research in the area of severe limb injury? And 2, can you provide specific examples of advances made as a result of this investment and research? Did you get all that?
Yes, sir.
Okay.
Yes, sir, I did. And thank you so much for that question. And I'd like to just start with a story, if I might, sir, on the outcome and the benefits of that research. I'm sure, and I would hope the committee is familiar with Sergeant Brandon Morocco, who was our sergeant who had a quadriplegic, basically amputations, and had bilateral upper extremity transplant. Based upon the research and based upon the support in this area.
He came to one of our hearings a couple of years ago. Remarkable. Excuse me for interrupting.
Yes, sir. No, and so we actually have some follow-up. Our team talked with him actually yesterday and his providers that are taking care of him. And he was very excited to and was really okay with us telling what's happening with him right now. And he is currently living in Dallas, Texas, the great state of Texas there, sir. Moved there from New York and is no longer requiring anyone to be a caregiver for him. So here is someone who had 4 amputations, bilateral limb transplant. The only downside, as he mentioned, wasn't even a downside. Is now he used to be right-handed. Now he's writing with his left hand because he's got more tactile sensation in his left upper extremity. So going from a person that had required a caregiver to now being able to take care of himself, to drive, to actually have the tactile sensation of writing, accomplishing all the activities of daily living on his own. And so, again, he lives in Texas with a fellow amputee that he met at Walter Reed.
So
It's
I assume
phenomenal.
based on that's a very good success story. There are other
Absolutely,
stories
sir.
like that. Do you have plans to provide sufficient funding for the continue this consortium to support this clinical research?
Yes, sir, we do, and I believe the orthopedic injuries that are sustained, of course, are complex, and there's the peer review program that's going to continue the research in those areas to ensure that that continues.
Okay. The other issue is spinal cord, something very severe. I personally have worked with Maryland shock trauma and Kennedy Krieger. Kennedy Krieger probably is one of the most advanced, they're right next to Hopkins, one of the most advanced in research of spinal cord. And they feel that if they receive more funding, continued funding, they'll be able to hopefully get people out of wheelchairs, especially our men and women in the military who are paralyzed as a result of their injuries, but it also helps our public too. And I think that we need to move forward in this regard. I know Jim Langerman, who's a quadriplegic member of Congress, a very a person who I have a lot of respect for, and I think now we're going to hopefully be able to make that a higher priority in the research, because we think that maybe down the road we might be able to get results in this area. Do you have any feelings on ramping up what we need in that research as far as spinal cord injury?
Absolutely, and as you know, sir, the spinal cord injury research program that was established back in FY09 has been, very successful in moving some of these projects forward. So the FY16 appropriations was $30 million for this program to support both innovative and high-impact spinal cord injury research. And so it's focusing, the funding, the projects have had the potential of really increasing the quality of life. And then just as you mentioned, sir, the Kennedy Krieger Institute, making the advancements in supporting research in those areas. So I believe we will continue to
Well, we look forward to working with you on that. Thank you.
Absolutely, sir. Thank you.
You, Mr. Diaz-Balart.
Mr. Chairman, thank you very much. What a privilege it is to have you here, and I just want to join the words of Judge Carter when he talked about it's amazing, frankly, what you've all been able to do, right, and the advances. But I want to kind of change a little bit to talk a little bit about mental health. And, we know that obviously folks, and not only, by the way, of the men and women in the military, but also their family members. So really kind of an open-ended question, which is, do you feel that we are making as much progress there as we are in other areas? Do folks have the ability to coordinate care, to have a long-term care? And also, if you also want to address a little bit about family members as well. So kind of an open-ended question, so I'm not quite sure who wants to kind of deal with it.
Sir, I'll start. We've invested heavily in the Department of the Navy in mental health services, both for our active duty as well as our family members, and the service chiefs have engaged aggressively to reduce stigma to allow our active duty service members to seek help, and actually we're seeing that. So more and more active duty folks are asking for help. Thankfully, the incidence of PTS is going down as combat operations have ceased, but the baseline mental health needs of our service members have continued, and we're meeting those needs. The challenge has been, as we take care of more and more active duty, more and more of our family members are referred to the TRICARE network, and it is a wonderful network of providers. Unfortunately, less than 2% of them have ever served in the military. So if you're a spouse and you show up, talk about a MEF or a MAGTAF or a MU, it's difficult to establish a therapeutic relationship. What we have done in our fleet concentration centers is to develop programs that we call Military 101, where we invite civilian providers to the hospitals on our bases and educate them about the military lifestyle, educate them about some of the stressors that our military families are undergoing right now. So when they need professional help, those folks are at least sensitized to those issues. At the same time, the services have significantly grown our support services through base and family support services, mental morale, MWR services, things like that, so that we also introduce them to the other service providers that are available. So we try and provide a network of services, a safety net, if you will.
And relatively holistic is what,
yes, sir,
I believe
absolutely.
is what you're saying, right?
Yes, sir.
Which is essential.
Absolutely, absolutely.
Great.
Thank you.
Sir, I would,
I'm
sorry.
Go ahead.
I would add to what Admiral Faison said. I certainly agree with what he just described, and In addition, we recognize that we have a responsibility to work closely with the Veterans Administration for the transition of care beyond the period of service. And so the DOD and VA have had an interagency care coordination committee working for approximately 2 to 3 years, and they have made some excellent progress in terms of coordinating the case management for particular service members with mental health conditions as they transition from DOD care into VA care.
Sir, one of the things I'd like to add also, you mentioned family member care. We also concentrated on especially our children in some of our Department of Defense schools, and even one school that's in Hawaii that's not a DOD school, but it has a high concentration of our military children. We have embedded behavioral health at the schools. This has really been greatly appreciated by the family members, so they don't have to bring their children out of the schools to the appointments and back, and then it also reduces the stigma. We also have embedded behavioral health with our units. We have over 55 teams with over 100 units, with our end state of having 65 of these embedded teams by end of FY17. And this actually, again, if they're part of your unit, that you see them on a daily basis, it makes it more accessible. We also, similar to that we treat buddy aid for trauma, we are teaching our, down at the lowest level, buddy aid for recognizing any behavioral health changes in their colleagues, because that's where it starts. When your friend to your left and right can see that there's something not quite right, they can actually intervene and get you to care as well. Again, reducing stigma and ensuring that we intervene at an earlier in the course of any concerns that they may be having.
If I could just take a moment to address some of the long-term and residential care. One of the things that we're doing at the DHA is we introduced ULB in November of 2015 to allow us access to more residential treatment centers so that we could continue to support those that needed a longer-term type of care for their behavioral health issues.
Could you define the acronym?
Oh, the
ULB,
the Unified Legislative and Budgeting in November to look for mental health parity, and we specifically targeted residential treatment centers so that we could gain access to that.
Thank you, Mr. Chairman. Thank you, Mr. Ryan.
Thank you, Mr. Chairman. I thought I was going to get trumped here when the minority ranking I was getting scared there for a while. Thank you so much. Appreciate you all coming in. I want to talk about a couple issues. One is more integrative health, what's quote-unquote alternative, which really isn't alternative anymore. And I know many of you are working on this in a big way. And I'd like to start, I want to talk about food a little bit, and then I want to talk about opiates. So there was some recent CDC guidelines that came out with regard to opioids, providing pretty good guidance for us. And I just want to quote here where it states, experts agreed that opioids should not be considered first-line or routine therapy for chronic pain. Pain continuing or expected to continue for 3 months or past the time of normal tissue healing outside of cancer, palliative care, end-of-life care, that kind of thing. Experts noted that clinicians should use additional caution and increased monitoring to lessen the increased risk of opioid use disorder among patients with mental health conditions, including depression, anxiety disorders, and PTSD, as well as increased risk for drug overdose among patients with depression. Previous guidelines have noted that opioid therapy should not be initiated during acute psychiatric instability or uncontrolled suicide risk. And I know we continue to prescribe high levels of opioids within the military. From what I'm reading, it's 15% of U.S. military post-deployment are using opioids as compared to 4% of the general public, and I know that obviously reflects some of what they're going through. So the point I want to bring up is that I also read last week a new study that came out from NIH, which concluded that mindfulness meditation works on a different pain pathway in the brain than opioid pain relievers. And because opioid and non-opioid mechanisms of pain relief interact synergistically, the results of this study suggest that combining mindfulness-based and pharmacological, non-pharmacological pain-relieving approaches that rely on opioid signaling may be particularly effective in treating pain. So I would like to ask, and I'll ask my other question too, and then you can feel free to answer both of them. What are you all doing to make sure that we continue to take this new knowledge that we have on how the brain works and how some of these older techniques are starting to really be effective in moving us away from more prescription drugs, and obviously the VA, and we're working on that as well. But tell us and share with us what you're doing and maybe what we can do to be a little more helpful to promote these kind of quote-unquote alternative approaches that are showing us some positive results. And then also on food, a lot of the depression and mental health issues we're finding out now also come from bad diets, quite frankly. What you put in their body evidently affects how our minds function and all the rest. And so if you could just talk a little bit too about what we're doing as far as nutrition and diets within the military now. We look at high-performing athletes, and everything I'm reading from some of the most successful teams, athletes, Olympians, so on and so forth, it starts with the diet. And obviously we have elite performers in our military, and we want to make sure that we're approaching their training with the same exact vigilance as we see some of these other high-performing people doing. So with that, I will turn my microphone off and allow you to answer the questions. Thank you.
Sure, thank you for those questions. First, I'd like to give you a good news story regarding the opiate use in our active duty soldiers initiating chronic therapy. Back in 2006, it was about 6.03 usage, and now in 2015, it's decreased to 2.98. So our teams have been getting after decreasing the use of opioids. In our pain management, we have 8 interdisciplinary pain management centers and 4 what we call the interdisciplinary pain management center lights that don't have all of the, what you said was alternative, but now getting more into the mainstream therapy that have multiple different physical therapy, yoga, acupuncturists, biofeedback, chiropractors, so they have the whole gamut of using other methods of pain control. For mindfulness, we have in our Medical Research and Materiel Command, they oversee, there are actually currently have 14 research projects on mindfulness to help improve and useful of that. All 27 of our Army Wellness Centers utilize M-Wave biofeedback as part of a mindfulness technique, and all of our behavioral health providers use mindfulness strategies within their inpatient behavioral health units and also in their intensive outpatient programs and other evidence-based forms of treatment efforts. And so we do see the value of that and are incorporating that in several of our interdisciplinary treatment centers as well as our behavioral health. And very quickly on the food, I have to give a lot of credit to my predecessor, Lieutenant General Patty Horoho, who really started the performance triad to get after what you mentioned, sir, it's sleep, nutrition, and activity, but the nutrition piece, ensuring that we have, improve the nutrition of our soldiers and our service members with the Healthy Base Initiative, and ensuring that there are healthy choices for our service members, reconfiguring our dining facilities to ensure healthy choices are up front. So a whole host of things that have really helped, I think, that's been embraced by our Army. It's not just a medical program, it's in the medical lanes now. Our entire Army has embraced that because we see the need, just as you mentioned, the importance of adequate nutrition. Thank you.
Sir, in the Navy...
if you could be a little, we want to make sure all members get some credit. If you could briefly respond to Mr. Ryan's comment, to each of you, if you wish.
Absolutely, sir. Thank you. We've leveraged heavily our experience with wounded warriors and invested heavily in alternative therapies. We actually have courses we run for our providers in acupuncture, just graduating a course of 92 recently. Our pain management strategy involves pain management teams at our major treatment facilities, as well as the use of telemedicine consultation for providers around the world. And monitoring is done through medical home, which is our model of primary care now. For food, we're a part of the Navy's overall initiative to change its physical fitness program from compliance-based to more holistically focused on health, and that includes a huge food component where we're looking at menus and diets on our ships and in our shore stations, again, to keep people healthy and on the job. Thank you.
I will just add briefly that we also have seen a decrease in opioid prescriptions to airmen, and we are monitoring that. I would also point out that 2 weeks ago, the Centers for Disease Control released their recommendations in regards to use of opioids for chronic pain, and the recommendations in that were very consistent with the strategy that DOD has been using since 2010 with use of multidisciplinary teams, the measures just described by my colleagues. Thank you, sir.
Mr. Graves.
Thank you, Mr. Chairman, and thanks to each of you. Let me share my appreciation for what you do to provide health and medical attention all around the world, a great long-standing tradition of our country and of the Army, so thank you. I just have a general topic I want to get your thoughts on as it relates to the Warrior Transition Units, knowing that General West last year, the Army made a decision to drop 14 of the 25 units, and I'm aware the decision was made after a number of our soldiers has decreased. The number of services that are needed has decreased, and that's certainly something that we need to be grateful for, going from 7,000 previously to maybe just under half of that currently. Yet it still seems that the Army sees that this plays a significant role, and I suspect you'll agree to that today as well, seeing how there's 11 units still remaining. But the decision was made to drop 14 units instead of maybe diminishing the size of the 25 units that are currently in place, or were currently in place. Can you just help us have an understanding of that the care still will be met where necessary, seeing how the 14 have been dropped, and previously it was in a lot of different facilities, including Fort Gordon in Georgia, and how soldiers can still expect to have that same care that we all want to make sure they receive?
Absolutely. Thank you for that question. Before we close down or decrease the resources at any of our facilities, and especially our Warrior Transition Units, there's a definite, deliberate process of it determining that the care and the resources needed are available, in another mechanism. What we also did is make sure that we, as we downsize the population, and again, as more of an attrition from when the service members who were going through the program were properly evaluated, treated, and then transitioned either back to the active service, back on active duty, or transitioned into the civilian sector. As the numbers went down, no new patients or no new service members were taken, and they were placed in areas where they could get the care that they needed. And so we are very methodical. The commander of our Warrior Transition brigade is watching that very closely. And we also make sure that there's an ability to expand back capability if we need it. So it's not being closed down. We work closely with the installations to ensure that that capacity still exists if we were, God forbid, to need to ramp that up again. And so each one of our individual soldiers are taken care of.
Okay,
Thank
good,
you.
good. Thank you. And I encourage you to keep that open platform, because I suspect there, as you review, and I know you do that, and that's applauded that you do as well, that if changes are needed or continuity of care is a concern, that you make the adjustments necessary and know that you have the committee's support in doing such. Thank you.
Thank you, Mr. Graves. Ms. Lowy, Ranking Member of the full committee. Welcome.
Thank you, Mr. Chairman, and thank you for your service to our country. I am particularly interested in advances to diagnose, treat, and cure kidney cancer. The incidence of this cancer has increased over the past 15 years, and early detection just does not exist. So by the time someone is diagnosed with kidney cancer, it could be stage 4 cancer. I'm very concerned about the rate of kidney cancer among veterans, particularly a potential link between Agent Orange and developing this debilitating disease. General West, could you please update the committee on your medical research efforts for kidney cancer? Would you rather get back to me?
Yes, ma'am. If I could take that for record, and I'll get back to you on the specifics for that. I appreciate it.
Thank you. And I would also like, as a follow-up on that, the incidence of kidney cancer among active duty and veteran populations, and what more can be done to research this disease. Thank you. I don't think I'm going to touch on electronic health records, Mr. Chairman. We've been talking about that for a very long time.
Well, I plan to focus on it. Well, I mentioned it, Mr. Visklosky, and I think every member of the committee has been totally dissatisfied I think the DOD's done a lot more than the VA, but we'll focus on that later. Your time.
Well, it's really shocking because I don't know how the private sector could focus, and it seems that the Defense Department is looking for a new, well, although you have a new system that is being worked on, whereas veterans are using Vista and upgrading that. So I'll leave that to you, Mr. Chairman. Thank you very much. Smoking. DOD has acknowledged that tobacco use in the military directly impacts military readiness and costs the department $1.6 billion annually in health care costs and lost productivity. According to Assistant Secretary for Health, Dr. Jonathan Woodson, over 170,000 personnel currently serving in the military will ultimately die from tobacco-caused death and disease. While the department has made some progress in the past few years, it has yet to announce it will implement all of the changes called for in the 2009 Institute of Medicine report, Combating Tobacco Use in Military and Veteran Population. First, could you tell us what is the department doing to transition to a tobacco-free military? What kind of resources would be necessary to dramatically reduce the prevalence of tobacco use in the military? What other federal resources, including the Centers for Disease Control and Prevention, tips from former smokers campaign, could be repurposed and used with military populations? And I'm sure my colleague to my right would be delighted to give you more information on mindfulness for this purpose. Thank you.
Thank you. I think there's been a concerted effort that continues today to reduce the use of tobacco. Certainly, all of us on this panel, you'll find no group more strongly committed to reducing the effect of tobacco on the health of those that serve and their families. It's the leading cause of preventable death in the United States, and clearly not in the best interest of those we serve to use tobacco. The Department of Defense has, there have been changes to the pricing for tobacco products, and in our exchanges, there's no longer any kind of discount for tobacco products in comparison to prices in the local community. In the Air Force, we issued a revised guidance last year that further restricted the use of tobacco on Air Force installations. And then on the medical side, we've really enhanced our efforts with increased emphasis on making the behavioral health therapies available to airmen and their families to help discontinue use of tobacco, along with medication therapy, use of frequent queries on the issue of tobacco use during every primary care encounter. And we've been encouraged to see that since 2010, the rate of smoking among airmen has been cut by 50%. Now, we have not seen a comparable decrease in smokeless tobacco use among airmen, so that's our focus right now, is to reduce the frequency with which our airmen are choosing to use smokeless tobacco. But we've made considerable progress in regards to reducing the smoking among active duty airmen.
I appreciate your focus on smokeless tobacco. This has been an issue of grave concern among many of us, and unfortunately, we don't have aggressive enough legislation to even evaluate the impact of Tutti Frutti and bubble gum. They're selling this in tobacco stores. I've seen them in my district. I go in and tell them I want to close them up, but hasn't done me good. So I really hope the military has done such great work in many areas of research, and I do hope you can be aggressive in this area, because from what I've seen, and you've seen it as well, the transition to Tutti Frutti or those other flavors is not keeping them healthier. So I thank you, and I'd look forward to more information in how you're pursuing this.
Will the gentlelady yield for 5 seconds? There is a great mindfulness-based smoking cessation program that came out of Yale that is highly regarded, highly effective, and very cheap. And they have an app on your phone that you can use, and it just walks you through over 15, 30, 45 days, how to kind of wean yourself off of smoking. And I think it would be worth, the military looking into, because it's such a low-cost, decentralized app that they can take with them. So, food for thought. Thank you.
Thank you so much. And if I could just make one other comment, because I appreciated your comments. I'd be interested in the focus, if you can follow up with us on nutrition. I was at West Point not too long ago, and one of my amazing fellows who was there 9 years ago, well, she said the menu hasn't changed since the last 9 years, and we were there, I think, on a Friday, and I saw those cutlets or whatever the heck they were. So I'd be interested in following up on the whole area of health and what you're doing to provide our extraordinary men and women the very best services and the best advice, and you do provide the best training in so many other areas. Thank you. Thank you, Mr. Chairman.
I'd like to claim some time for myself here. Women in the military. All occupations are open to women. I served with Mr. Ruppersberger on the Naval Academy Board, and when we gave the green light, or at least maybe the Department of Defense did, women on submarines. What are we doing today, given this this decision, which I support, to assure that women or their medical needs are being adequately addressed? I have to say, on the VA side, I'm shocked, but that some installations still haven't gotten the fact that we have women veterans. What are we doing relative to meeting the needs of women in the military today?
Sir, I can address the Navy since you mentioned that. We have if you want to do the Navy, that's right, but we also have sitting at the table two of your colleagues here. And I'd like Admiral Bono, and then General West, and then you, Admiral, if you don't mind. I'd like what are we doing? You know, and I'd also like to know what there's been an uptick in congressional directed spending. I assume all of you are familiar with member and obviously service interest, and how that interacts to make sure that when we make those investments in R&D, whether we're making sure that women are part of some of the beneficiaries.
Yes, sir.
Please. Thank you.
Thank you, Mr. Chairman. So I think all the services, and I know they'll speak for that, we've always paid attention to the health of our women in uniform, and so we've always had robust programs for that. But to your other comment about the care of women in the VA, many of us partner with the VA to provide women's health services, such as OBGYN, mammo, other screening modalities, and so there is that effort to help the
Respectfully, there are VA hospitals,
yes, sir,
that have not met that challenge. What I'd like to see is whether our medical facilities are doing everything,
yes, sir,
that women need to look after themselves, so we address the issue of readiness for both men and women.
Yes, yes, sir.
Yeah.
And as a matter of fact, one of the things that we've done at a policy level is recognize that a well woman visit would also include preventive as well as acute care for certain conditions that are women-related. So yes, it is something that on a coordinated basis with the services and at a policy level, we're making sure that women have access to all the care, both women in uniform as well as all of our women beneficiaries.
Just to put a point on it, we have a lot of military installations around the world. We have women, you know, on the battlefield in a variety of settings. Sometimes we know where they are or where they're not. We may not know, but are their needs, their medical needs being, we have the figure 9,800 comes to mind. Yes, when we talk about Afghanistan. There are obviously women that are an important part of those components.
Absolutely, sir.
And how are we meeting the needs of women, whether they be, you know, on the Korean Peninsula, whether they be in Afghanistan, Iraq, Sinai, other parts of the world.
Well, I think you'll hear, too, from the other services that as our MTFs, where we do a lot of our training, encompasses the full spectrum of care for men and women, and that allows our providers who are forward deployed down at a later date to have those skill sets in taking care of our women who are deployed and on the battlefield. So we do ensure that the full scope and full care that's needed to support our women in uniform is available.
Sir, thank you. And again, I would like to, recognize my predecessor, Lieutenant General Horoho, for her efforts in establishing Women's Health Service Line, doing the task force on women's health to ensure that conditions unique to women are addressed. Several of the things that were done was to determine ways to prevent injury. As we open up the MOSs, the military occupational specialties, are there certain stresses on the skeleton that might be mitigated by certain interventions? One of the things that they found was, maybe a multivitamin to decrease stress fractures. Body armor, just the configuration of body armor, so it's more adaptable to the woman's body habitus to prevent stress points on resting on the hips or too high on the neck. And so just small things like that, which appear small, really impact the ability to do that. Other specific research, for example, there was a study that found that women paratroopers, if there was the jump during certain periods during the menstrual cycle, when certain levels of hormone were not present, that could predispose them to injuries to for their uterine injuries or prolapse. And so studies like that are unique to women have been done and are going to be continued to be done. So it's an extremely important aspect, not only our women, but all of our service members' health. But things that are unique to women will be addressed. And I believe as we open up establishing standards in each MOS to make sure that it's a standards-based, once we know those standards, to ensure that we're not putting any of our service members, men or women, in positions that would cause harm to them is being worked.
All right, Admiral.
Thank you.
Yes, sir. We've significantly increased the training we provide our primary care providers, both those in our shore facilities and those afloat, since women are on most of our platforms today, to attune and sensitize them to the women's health issues that they'll be dealing with, as well as provide consultative services and support if they've got questions. All of our MTFs have got very robust women health programs right now. All our preventive medicine services for women are basically available on a walk-in basis on demand, so mammography, prenatal counseling, and things like that are all available. In addition, as General West said, we've noticed, especially for our female Marines, the importance of sports medicine and musculoskeletal conditioning. So we have actually female-specific clinic and services to help them in those areas. A variety of research programs that are ongoing right now, especially for women in submarines, as I'm sure you're very well aware. In guiding all of this is a very senior steering group that looks at this on a regular basis to identify new opportunities and look at the outcomes of the research to help inform where we need to put our efforts next.
The Air Force.
Sir, we continue to support medical research to do two things occupationally to improve the ability of women to perform in Air Force missions and occupations. One is particular to air crew is the accommodation of female air crew members, particularly in long duration missions, but also in researching our physical standards in some of our missions, such as special operations, to ensure that our physical standards are really set so that they actually do match the requirement of the mission, so that we give female airmen a fair opportunity to compete and be selected for those special operational duties. I would also add that Admiral Bono mentioned special aspects of medical care that are particular to supporting women in the operational environment. Our military family physicians, it so happens, are meeting right now in Denver. I attended one of their sessions yesterday that actually was a women's health session, and it was focused on training our primary care providers to be able to provide women's health services in the operational environment.
Just one comment. We spend a little over $1 billion on congressionally directed funding. I think it gets pretty high marks. It's certainly members are keenly interested in some of the advantages that R&D provides over and above what we do with the National Institutes of Health. And so I do hope as you gentlemen and ladies take a look at that congressional contribution, I want to make sure that every aspect of all those R&D projects primarily, that there's some tie-in to the needs of women as well. Mr. Womack, thank you.
Thank you, Mr. Chairman. Admirals, Generals, thank you so much for your service to our country and what you're doing in the field of DOD medicine. General West, particularly, welcome to you. I value and continue to value my relationship with your predecessor, General Harho, who was a tremendous representative of Army medicine, and make note of the fact that we are making quite an investment in the health and well-being of the men and women in uniform. It's crucial, and it's led to some amazing results and innovation. In fact, as has been the case the last 2 years in front of this committee, I have talked about the story of Sergeant Brendan Morocco. I continue to be amazed about it. When I talk to my constituents about his particular situation, there's never a dry eye left. And it is a credit to our nation that we have the capacity to do what we did for that young man. So my initial question is on the subject of regenerative medicine. And there have been a lot of great things that have happened, and I'm sure the sky's the limit on things that we can continue to do when we engage the scientific, the medical, the engineering community, and what have you. So can you just take that softball that I've kind of thrown out there and talk to us about that particular area of medicine?
Yes, sir, and thank you for the question. As I mentioned earlier, the success story for Sergeant Morocco now not requiring any caregiver, and on one medication for rejection, for transplant rejection, and he goes in once a year to the VA locally, and then once a year for treatment. Amazing story. So in regenerative medicine, the DoD has awarded more than $200 million for the regenerative medicine efforts. That includes the Armed Forces Institute of Regenerative Medicine. And specific research areas or focus in those areas are the burn treatment and skin regeneration, the craniofacial, craniomaxillofacial regeneration, and also, as mentioned, the extremity regeneration. And also for, because of the nature of our wounds, a lot has been done for the genitourinary and lower abdominal reconstruction, as well as the vascularized, and I'll have to read this one, vascularized composite allotransplant, and which is the hand and face transplant. In fact, the DoD has quite a bit of effort in the hand and face transplant, which is remarkable given, again, the nature of the weapons that are being used and the horrible injuries that they're having. But just one on the burn and injury and the skin regeneration products. There's a RECELL, basically a spray-on skin. I had the opportunity to see that when I was up at Fort Detrick not too long ago. It's just incredible. An aerosolized spray that has the skin components that they put on, burn patients, and actually looks, cosmetically looks better than in the old kind of the checkerboard look that you get with the multiple punch graft transplants. So that's one where the cosmetic result and the need to reduce the pain that individuals have to go through with multiple washouts and debridements. You clean them off once and then you spray that on, and just the remarkable results that you get with that. And then two promising products that are currently being used there in the tech-based research that we hope will be advanced to the advanced development soon is the Stratigraft and also the Carryover, which are two burn gels for treatment of severe burns. So we really appreciate the support and just are happy to be able to report that there's some great advances that are on the horizon in these areas.
Mr. Chairman, if I still have time for one more question, I want to just kind of throw this out on the table for all to take a swipe at, but it's about readiness and the health and well-being of our member soldiers, sailors, airmen, Marines, critical to the overall readiness. And through sequestration, we're having to buy back some readiness issues created by the sequester. We are spending more money in training hours, facilities, equipment, this sort of thing. What I want to make sure that we are not doing is that we are not paying any of those bills by taking money from you that go right to the heart of a commitment that we've made to the men and women in uniform who have gone downrange on our behalf. So how have we seen the health readiness fluctuate through this very difficult threat and budget environment that we have to kind of find a sweet spot somewhere in there?
I'll just throw it open for anybody.
Sir, the resources we have in the Defense Health Program do ensure that we are in a position to provide the care we need to provide to our beneficiaries, primarily being the active duty and the active duty family members. In regards to the effects of the sequester and the health readiness of the force, I think one thing I would need to relate is that I think we are still seeing the impacts of the sequester on the Air Force's overall readiness in the form of stress on the force. For example, our aircraft maintainers, there was a good deal of deferred maintenance during the sequester. And as the Air Force has expanded its capabilities, we've seen that our maintenance community still struggles to catch up with the significant backlog of maintenance that was created during the hiatus during the sequester. And we do see indicators of health impacts from the stress on our maintainers in the form of that's the medical skill set in the Air Force. I mean, the skill set in the Air Force with the high suicide rate, for example. But other instances like substance abuse and things like that. So that's one relationship I would point out between the sequester and health.
Thank you, Mr. Womack. Mr. Visklosky, and then Ms. McCullum.
Thank you, Mr. Chairman. A number of issues were mentioned. I just associate myself with them. We've been on alternative therapies, mindfulness, and would want to associate myself. I can't imagine the stress military personnel are under. And being an accounting major, so what do I know? My sense is sometimes less is better than invasive, and do think there's value in pursuing that. Secondly, smoking was mentioned. My understanding is that for active personnel across DOD, 24% of the population smokes, 19%. You've already stated you're very, very committed in that effort, and I absolutely believe you would, again, encourage you. Food was mentioned, and had a meeting with one of the adjutant generals for one of our National Guards, and asked, what is your biggest problem? And the general said, fitness. And I understand it. It's buffet style, and I love it. But I encourage you on the food side. The chairman talked about women. One question I do have is, my understanding is more than half of the students in medical school today in the United States are women. Are there an increasing number of women physicians in the services? Is there a shortage of women physicians? Could you address that?
Sir, thank you for that question. And again, when I went to medical school at GW, it was about 50% as well then. You know, that was a long time ago. But
oh, was it?
Yes, it was, sir, long.
It was that long ago.
In the 80s, 1980 something. So, so we had actually an increased population of women, and I know in our medical schools, I don't have the exact numbers, but I wouldn't say that there's a shortage of women. I think that those that apply, we've got a great, cohort of very highly qualified women physicians in all specialties. And in the MTFs, and I've seen them in our Navy and Air Force colleagues in the deployed environment, again, surgical specialties, primary care specialties. So I wouldn't say there's a shortage because we've got, I think, a good motivated group of individuals who want to be military physicians.
Sir, I'd echo what General West said. We're not seeing a shortage as well. We've met our accession goals across the medical corps for all our medical students that are graduating. A significant proportion of them are ladies because of, as you said, they've comprising a larger percentage of graduating medical school classes, and they are distributed across all our specialties. I go even further. They're also distributed across our operational forces. Mm-hmm. So I was down in Norfolk last week and visited several ships on the waterfront, many of whom had women physicians on board. And that just adds to the diversity and robustness of the medical footprint and the services that we provide our operational forces.
If I can move on, have a couple of more questions and just kind of brief. I appreciate, General Ediger, that in your testimony you talked about examples in the military medical mission. Too often we are very focused on the congressionally directed mission. And there's been a range of conversations. Are there any gaps today that do cause you concern that we could be doing a better job? There's a need, any funding issue on the military medical mission side? Mr. Rupersberger mentioned a couple others, so it sounds like it's okay, but it just is there some little slice we're missing?
Sir, I would say that our biggest concern in terms of our future capability really relates to our readiness. And that's because the care we take forward now is more complex than ever before. And so that really means that we need to keep the deployable medical team ready to go forward with a broader range of capabilities than they've had before, because we now have the technology, the knowledge, and the techniques to do more in a forward environment. For example, we do vascular surgery techniques and neurosurgery in field hospitals now. That's not something we would have tried when I came in the military. And so in order to keep our teams ready, I think it's really key that we be able to give them the opportunity to provide specialty care in our hospitals of a more complex nature than our population generally provides. And so in my statement, I referenced our difficulty in terms of always capturing the volume of referral care from perhaps the Veterans Administration. That really helps our readiness. It also produces good care for the veterans at a savings to the government. And so that's the concern I have right now about our future readiness is our ability to successfully pull in more complex specialty care to our hospitals to ensure our deployable teams are ready.
Would it be a money issue at all, or is it just, again, the emphasis in organizing, training, and the delivery of services?
Right now, frankly, the issue I just referenced is more of an administrative issue in terms of some restrictions on the use of certain types of funding. Yeah.
Okay. Mr. Chairman, if I could, the Jacob Sexton Act, which was contained in the 2015 Defense Authorization Bill, required annual mental health screening for active Guard Reserve military personnel. During last year's hearing, I understood that the agency was in the process of developing policy and implementation for conducting those annual assessments. Admiral Bono, where are we today in that?
Yes, sir. Thank you very much for that question. We are in the process of being able to provide a response of our initial evaluation of that. We were asked to evaluate that as something to potentially apply, and so we will be providing a report to that shortly. We wanted to be able to look at the feasibility of being able to provide that kind of screening as requested.
Do you have a date on when the report will be completed?
I looked at I don't have the exact date. I'll take that for the record. I do know that we're in the process of putting that together, though.
Thank you, Mr. Chairman.
Thank you.
Thank you, Mr. Visclosky. Ms. McCollum.
Thank you, Mr. Chair. I'm trying to do triage. I have 3 questions, and I think they're all equally important. So with the Chair's indulgence, if I quicken my question and we can get to a reasonable response, maybe I can get through a couple of them. The first one I want to just take a second, though, is talk about what we've learned from the outbreak of the Ebola crisis and how you were worked on this. West Africa, just a short while ago, there was resources deployed by the U.S. Army, saved thousands of lives, and the effective response really speaks to the values that we get from funding infectious disease research, the development of the U.S. Army medical research and material command. So with so many global health challenges out on the horizon, I want to make sure, as people have been talking up here, that you have all the tools that you need. So could you please maybe tell us what we can be doing to make sure that you have the proper research, the proper equipment, that we give you time to reflect from lessons learned, because now people are talking about Zika. And I've heard the military be talked about being dispatched in that. So can you maybe tell us a little more about, particularly General West, some of the best practices that you learned from the Army's response? And can we apply these lessons learned to future global health emergencies? And are there things that are in other portfolios that make you able to do your job working with the CDC and others?
Ma'am, thank you for that question. I'll try to be really brief because I know that you have a couple of those. First, I want to say thank you very much for all the support for the research funding to get to the point that we are today. what we learned from the Ebola crisis in response to that, it was a multi-service effort. We also had our colleagues from the Navy labs that assisted in that as well. And so the research that, with the ability to have a rapid test for Ebola, again, save thousands of lives. Our research on all the other infectious disease areas, such as malaria research, and for Zika now, the DoD had the flavivirus research, and Zika is part of that family. Actually had some research ongoing for that, or starting for that family of viruses. We're able to apply that and work with CDC and others in a methodical way to come up with hopefully a vaccine for that. So we do appreciate the research dollars, and I believe that it's, we're making sure that we have lessons learned and then other advances that, that will ensure that we can go after those globally, relevant infectious diseases.
Ma'am, if I can add on to what General West said, the one thing that I took away from this was the value of an agile military health system that can rapidly respond. There's been a lot of discussion about what's the role of the military health system. If you look across the world, there's only 2 nations, China being the other one, that maintains a standing medical force ready to surge on a moment's notice to a crisis, such as Ebola or now Zika. And so the one thing that I learned was the value of having something that's ready to go out the door very quickly with that. Thank you.
Thank you, Mr. Chair. I'll combine my other 2 questions. First one's going to be on concussions. So late last year, there were a number of concerning stories in the New York Times regarding concussions at the service academies. The articles explored concussions sustained by cadets both in physical education programs and during free time on the academy's grounds. So given that one of the enduring legacies of the wars in Afghanistan and Iraq is our attentiveness to concussions and traumatic brain injury, I think it's important for this committee to get an update from the service branches on the prevention and treatment of concussions. The protection and treatment of our cadets, members of garrisons, it's all important that we do that, and we need to also not only be doing the prevention side, but when we have the concussion recognized and diagnosed, to make sure that we're fully watching what that service member is going to need in the future to mitigate a future risk to brain injury. So I'm going to the Traumatic Brain Injury Treatment Center at Fort Belvoir later this week, because I want to learn more about these facilities so that we can be helpful as a committee to make sure that you have what you need and necessary funding, because this is an injury, as any injury, not only affects the service member who is the recipient of a tragic injury, but it affects a whole family too. The other question I wanted to learn more about, and I've been, I thank the committee for its support in trying to get information and move this forward in the past, has been in biomedical technology research program at the Defense Advanced Research Projects Agency. And one of the things that I've been trying to focus on as I've been speaking to female veterans who are amputees, they often find themselves at a great disadvantage to male amputees, who, when it comes to adequate prosthetics, find that they don't have the same scale. You know the medical terms, I don't, but it's not a good fit for them. And when it's not a good fit, it affects how well you heal, how active you become, but it also can do joint damage in that. So if you could tell me a little bit about concussion and what we're doing in prosthetic. And I know that the artificial limbs are also important to male members who are receiving them, who have been wounded in war. They've told me about the discomfort, but when you talk to some of the female veterans in particular, and now that we're seeing them sustain more of these very, very severe and critical injuries, but when treated right, can be life-transforming. Could you tell me a little bit more about prosthetics and concussion?
I'll start real quick on the traumatic brain injury. First, for the TBI, the MRMC, our Medical Research and Material Command, manages the largest TBI research portfolio in the world. Literally, it's $844 million, and there's over 590 funded research projects, and that's multi-service and interdisciplinary to find cures. So there's a lot of work and a lot of good, good research that's coming out of that. Boxing at West Point, having a plebe at West Point that just completed first semester boxing, and as a parent, I know I'm very concerned to ensure that that's as much mitigation to prevent injury is present is really foremost in my mind. And so, specifically for boxing, the mitigation strategies. And I asked my son, and they actually do keep this, do this is cadets wear the padded gloves, headgear, and mouth guard, and then they limit the amount of types of strikes that they're allowed to have per round to minimize the amount of injury. And he said that they're pretty strict on that. Once you throw across, once you've done that, then that's it. And they're monitored very closely to ensure that there's the safety of that. They're also part of the Grand Alliance with the NCAA, which has lines of effort for concussion management, ensuring that the symptoms of concussions are recognized early. And then Mind Matters Grand Challenge competitive educational project that encourages the innovation to change the concussion safety in sports. And so they're part of that to mitigate the strategy for that. And for prosthetics, you're absolutely right in ensuring that we have all of our service members that need prosthetics, that they're custom fit, and most of our, in fact, all of our prosthetics are custom made for the individuals, based upon their limb size, their circumference, and the number of amputees we have, unfortunately, in our female population is not as large as 1,600 overall from OEF alone, not to include our motor vehicle accidents and things like that. And the number of women is in the 20s, so it's a smaller number. But it's important that we make sure that we have the customized, prosthetics for them as well.
I didn't understand your statistics, 1,620?
So the total number of amputees of all in the Army is about 1,600 total, and then for women it's 20. I had
Okay, thank you.
So it's a small percentage of women that sustain amputations.
Could I do two quick follow-ups? One would be on, I know West Point has now banned the pillow fights. They knew it was a problem. They knew what was going into some of the pillowcases. If you could elaborate on what the service academies are doing. I mean, young adults will be young adults, college students will be college students, but when they're in the charge and when you become aware of things that are not healthy, that they're doing, I know that you try to step in and mitigate, whether it's alcohol and pillow fights also were something that were causing concussions and traumatic brain injury. But the other question I have going back to the prosthetics is not only the customization of the prosthetics, but it fits on, it attaches to bone at some point. And that's something that I was hearing that at the VA institutions working with the DOD, that we were looking at how we mitigate some of that pain, and then the bone in and of itself wearing out, especially in women because of their joint structure and everything. Even we're finding that more of a challenge as well. And then after that, Mr. Chair, thank you for your indulgence.
Thanks, ma'am. I'll take that for record to determine if there are any specifics, if there's, supplements or things that would help strengthening the bone, but I'll get with our experts and get a good answer for that one. Thank you.
Thank you. Thank you, Mr. Just an update on Brussels since you've been here. 6 American citizens injured, including 5 family members of the U.S. military. That's pretty horrendous, and I'm sure we're meeting their needs and will be meeting their needs. I just have some questions. This morning we had the Army caucus. General West and I sat beside General Dyson, and I asked about how many of those in the military today are married. Do you know the figure of those that are married? And this sort of gets to the whole question as to the military medicine addressing the needs of families. It's quite a high figure.
Yes, sir.
You'd agree?
Yes, sir.
I heard the figure 45%. Admiral, do you?
Yes, sir.
Yes, sir. It's about half of active duty service members are married.
I just have a few questions. Hearing loss, huge issue. People come to see us. Eye care, we've, I think members of Congress have raised the whole issue of the number of people that have been in the battle space who come back with eye injuries, and at times I sort of worry that maybe we're not, focusing enough on that. Dental. Could you briefly comment on if any of you have any observations that this, and then of course you have the issue of the Guard and Reserve generally being ready. We have one Army, I assume we obviously have one Air Force and Navy, but the readiness aspects that relate to these pretty basic issues.
Yes, sir. In regards to the reserve component in the Air Force, the Air National Guard and the Air Force Reserve are very much a part of Air Force operations day to day, and so they have the same readiness standards that we have in the active force. And it is true that several years ago we had some lagging indicators in terms of medical readiness in the reserve components, but the Air National Guard and the Air Force Reserve have both made impressive progress in terms of bringing up the medical readiness of the individuals serving in the force, and they are now on a level commensurate with the active force.
But I assume all of you would agree that there are some continuing issues that relate to hearing loss and eye care. If you could
Sir,
talk about that briefly.
I'll address the hearing loss because this is a big issue for the Navy.
It gets to the whole issue of concussions. The number of people who come back from multiple deployments who have degraded hearing, I mean, it's pretty shocking.
Yes, sir. So the Navy convened, and I actually chair this, a very senior work group that reports directly to the Vice Chief of Naval Operations on specifically hearing loss. And we monitor trends among active duty, both those that are in shipboard and other operational environments, as well as those deployed. And part of that is a collaborative with the Office of Naval Research to look at emerging technologies to improve hearing protection, if you will. And there are several pilots and research studies ongoing right now in the Navy to look at how we might do better in protecting hearing loss, realizing that it's such a huge issue for our active duty. And the Navy, by its very nature, is a noisy environment. So we're very engaged on this.
So I'll just briefly talk about the protective for eye, conserving sight. The Army has a very rigorous and aggressive campaign of ensuring our service member wear their protective, anti-ballistic, their eye pro, even in operations, in garrison, just getting used to wearing their protective eyewear at all times. So that's really important. And also in our traumatic brain injury, our Intrepid Spirit Centers, we've got neuro-ophthalmologists and neuro-optometrists who actually can identify some of those visual problems that might exist, might concur after concussion or traumatic brain injury, more severe traumatic brain injury, and then treatments for those problems with their vision.
Just a couple of other comments. Let me give a shout out to the people who work on the prosthetics at Walter Reed Bethesda. It's pretty an amazing operation. It was, I think members would be, I know number of members have been out there to see it, but in reality, the things that are done, every 6 months, maybe in a year, to, should we say, meet the different changing physical characteristics that come with us getting older or perhaps gaining weight. It's a miracle operation out there, and certainly we need to make sure that women or their issues are addressed. Changing the subject, the hospital Landstuhl, its replacement, maybe that's not in your purview, but in reality, I assume there must be some degree of frustration that we don't have an upgraded medical facility. Are you familiar with what's going on over there? And do you have any concern about progress being made? It's not the jurisdiction of our committee, but it is our jurisdiction because when we set that up, we need to make sure that we have the most modern, accessible facility as possible. Any comments?
Yes, sir, and I can comment. When I was the commander of the Europe Region Medical Command, we were in the process of working through the requirements for the new facility, and we also worked with, there's also our Air Force colleagues that have a requirement for an upgrade of their facility there as well. So we made sure, working with the German government, of course, because there's a requirement to meet the code for that as well. But I believe that we've got the right capabilities that are built into the new structure that's going to be built for for that replacement facility.
Glad to hear it. Lastly, it used to be more frequent. We'd run into those who've been injured in the Middle East relative to the whole issue of medical discharge. There's some who are so devoted, as I'm sure you know all too well, and we know too well, to staying with their units and keeping their loyalty to their specific service and to their buddies. Any comments about whether we've made any progress or any observations on the whole medical discharge situation? It's, I think, of concern to all of us.
Yes, sir. One of the things as far as the unit integrity and just a real quick comment on that, some of our service members, there are actually programs now that, service members that were injured were evacuated back unconscious for closure actually have programs where they fly back to the area to see where their unit was to get closure in that area. But as far as the process for our IDES system, our Integrated Disability Evaluation System, ensuring that our service members get the proper evaluation, and actually it's, I think, a better system for them because it's integrated with the VA, and they get not only their military discharge, physical, but before they get their DD-214, they've already had their VA evaluation and their percentage, so they don't have to start the process all over again once they're discharged from the service. And that's been we've gotten good feedback that that was kind of a one-stop, had all that before they left service, so they weren't kind of left on their own to try to figure it out after they got out. Over.
Sir, when somebody's injured, if they want to stay on active duty, we make every effort to keep them on active duty. We find they have better outcomes. They tend to do better long term. But more importantly, they're good role models for our other soldiers and sailors and Marines. So we try and keep them if we can. When they can't, that's a mutual decision that we make with the service member. But wherever we can, if they want to stay on active duty, we will make every effort that we can to keep them.
We're glad to hear that. And we haven't really had a focus on electronic medical records, but in reality, that transfer to the VA system is a major step, and we certainly having a seamless system is one element of reassurance that, quite honestly, that they deserve. Mr. Ryan.
Thank you, Mr. Chairman. I just have one quick follow-up, more along the lines of the Air Force with the Zika virus. My district is home to the 910th, which has the aerial spray unit, and so I was just curious about any kind of coordination that may be happening with the health side, with kind of the deployment side, and how that would work, and making sure that we are coordinating. I know they're involved in a lot of training operations, and they're all over the world, and we want to make sure that what you're doing is connected to their ability to take care of the situation if need be. So if you can answer that, and making sure that they have the capabilities they need to be able to get this stuff out.
Yes, sir. Requests for support through aerial spraying, for example, for mosquito control, come in through U.S. Transcom or the Air Mobility Command, and there are surgeons there who are advising them in terms of the medical aspects of that. For the Zika virus in particular, we know that particular mosquito, probably the most effective way to eradicate it is through killing the larva, which is done at a different method than aerial spraying. Aerial spraying has some impact for the mosquitoes that are grown and flying about, But I think the focus in terms of controlling the Aedes aegypti mosquito is on the larval stage of that, which unfortunately requires an on-the-ground kind of presence. But yes, when there are requests for support through aerial spraying, we do have a senior medical representative in the commands as they consider those.
Mr. Visklosky.
Thank you, Mr. Chairman. I have two questions for the record. Admiral Faison and would compliment the Navy. A couple of years ago, we had questions about mental health, and the Navy had, at that time, about 123 programs. My observation being you have none, if you have that many. In my understanding, the Navy has been very, very focused, and better have two questions for the record. But again, want to thank you. First question is, we had long discussion last year about the compound pharmacy costs. My understanding progress has been made. But given what I feel were the immoral activities, if not outright illegal activities, of some of these people who compounded, were any individuals or businesses debarred from any further contracts with the department, and has anybody been prosecuted? Because I fear people every day connive, and if there's never a signal sent, there's a price to be paid for stealing money. And I have two more questions, so just tell me you debarred somebody.
Yes, sir. We have identified those pharmaceutical companies that have done just that, and they're no longer able to participate in providing care or frauding any of our patients. Yes, sir.
Good for you. Do you know where there were any? I appreciate that very much. Were there any prosecutions? Do you know?
Yes, sir. We've been working very closely with the Attorney General and the Department of Justice, and so we actually have some sting operations in several areas. So yes, sir, we have prosecuted. Well, we haven't, but we've let the Department of Justice do that.
That was just so wrong on many levels.
Yes,
Second question is on sexual assault. As I understand it, as far as those who help individuals who have been assaulted, are there special training programs for those positions, and are we adequately funding that training program?
Yes, sir. In the Navy, we have 331 providers that receive special training in sexual assault response. In addition, there's additional programs for victims advocates and other support services that are brought to bear when there's a victim of a sexual assault. Those programs are well funded.
Okay.
They're well participated. Yes, sir.
Last question I have, because a lot of our facilities are older. There's been a lot of attention paid to lead levels in drinking waters in the state of Michigan, for example. Any problems in the military you've ascertained? Is there testing going on for that particular problem?
Sir, we do. We're working with the Installation Management Command for the Army. I'm sure this is similar with the other services of diagnosing any type of or evaluating the water. We found that there was a couple of installations that had, due to the disposing of firefighting sprays that contain certain contaminants, PFOA, which is the perfluorooctanoic acid, and others, ensuring that there's not, elevated levels. So they've actually been screening for that, and they found at 23 installations, they tested the water for that level, found none, and those that they did find some traces that were below the, parts per billion that was normally. So we do routinely test water for contaminants. Thank you.
Yes, sir. Same thing with the Navy. We have a senior board. We meet quarterly. I'm a member of that, and we look at water quality at all our installations around the world. Specifically for the firefighting chemicals, we have a program right now to aggressively test all our facilities around the world with that, to include 1 mile upstream, or uphill, if you will, in the water gradient. And where we find exceedances beyond the public health advisory, we provide bottled water for those folks.
Thank you very much. Thank you, Mr. Chairman.
The Department is again proposing to replace the current TRICARE program with a more consolidated TRICARE health plan. The Department claims that the consolidation will allow for a simpler system while not changing the health care of active duty service members. Beneficiaries will have two, and correct me if I'm wrong, two care alternatives: an HMO-like managed care option, which focuses on the use of MTEs, which you've referred to, and a PPO-like unmanaged system that offers more choice but at a higher cost. The proposal would save TRICARE about $1 billion annually, starting in fiscal year 2018. Where do we stand on this? And you're assuming, of course, some authorization, which indeed would provide with us with some savings. Are you prepared to talk about this program?
Yes, sir. Thank you very much. We are proposing TRICARE Select, which is our HMO model, and TRICARE Choice, which is the PPO, the Preferred Provider Model. And what we hope to be able to do with that is provide our beneficiaries with greater choice to the types of health care that they desire. But we've also ensured that access to the MTFs, which is our main readiness platforms, are preserved. And so we've incentivized being able to go to the MTFs regardless of which program our beneficiaries choose.
You had any initial reaction from the authorizers, or is it the annual reaction? Otherwise, our committee is going to be stuck with quite a large bill here.
Yes, sir. We've had a lot of interaction, primarily, though, with our beneficiaries to make sure that we have an understanding of what their interests and needs are. And so we, as you mentioned, have looked at this and have been able to project the savings that you mentioned there.
What's your interaction with the authorizers to date?
The authorizers to date have been just as we've submitted that. But that's
okay. Any further questions from members? Yes, Ms. McCollum.
Not a question, but more trying to understand something that we have been doing as a Congress. There has been a movement, and at times it is extraordinarily proper to do so, that our veterans can access non-VA facilities and be reimbursed. But then when it comes to TRICARE, it's the exact kind of opposite reaction that the private sector not be part of it. And I think you're right that we need to bring veterans groups, service groups, we need to bring military families, and we need to figure this out so that people are getting good quality health care when and where they need it, and so that it's sustainable, because if we don't get a handle on it, I'm afraid of some of the backlash that could happen a decade from now with health care costs. So I don't know how we rectify these different ways in which we approach health care. In one hand, it's good to start looking at, taking people away from the VA system, but at the same time, when there's discussions about opening up TRICARE, it doesn't receive the same kind of open-mindedness as it is. So my question is, you said you've been talking to people. Are people afraid of the cost? Is that the reason? Is it the cost? What's going to happen with prescriptions? What happens with copays? Is it the cost, or is it where they're receiving the care?
primarily the conversation that we've had with our beneficiaries has to do with being able to access the MTFs, which is something that we've all actively taken part in addressing that.
So, General West.
So one of the concerns, I think the cost, from my perspective, as the responsible for providing, capable medical capabilities to the operating force, it's a little bit different mission than the VA. We have to have capabilities, and so the concern is if too much workload of the diverse patient population is diverted from our military treatment facilities, which are our readiness platforms, then we might not have the diversity of patients and the ability to keep our force, prepared and ready to go, because we do much more in those military treatment facilities than just care. And so having that diverse population keeps our folks ready and our teams ready, because it's not just the physicians, it's the nurses, it's the techs and things like that.
And Mr. Chair, this has been a concern of mine, because as our teaching hospitals are finding themselves under more and more pressure all across this country with reimbursements and the cost of medical school and everything like this, you're becoming the platform of teaching hospitals. And if you don't have enough, my children were delivered by a person who got their training in obstetrics and gynecology in the U.S. Army. I mean, you're also a significant teaching hospital. If you don't have enough deliveries and things happening and routine things happening, you can't train people on it. So I think that that's part of the conversation that also, that people don't talk about it unless you talk about the impact it's going to have on your ability to not only train people to be providing first-class medical care to our servicemen and women, but also for those who go back into civilian life later on. It is a platform for teaching hospitals, for whether it's burns, whether it's deliveries, whether it's prosthetics, concussions, and that, like no other. And it would be devastating to this country to lose these teaching hospitals.
Ma'am, if I can add on to that as an operational imperative, we train about 60% of our doctors. And the reason we do that is because we send doctors to very isolated duty afterwards. It's not they don't go down the street and set up shop and there's a hospital in the community and other doctors to help them out. It's very isolated duty. The other reason we do that, and ma'am, you mentioned this, is if you look across our nation right now, there are not enough residency programs to support all the graduates coming out of medical school every year. There are 1,000 less residency slots. We have 4 surgeons that just didn't match to go into a training program in the Navy. So that's 4 surgeons that I can't get into training this year. So it's a big challenge, and we're very worried about pushing things into the civilian sector because we won't have the clinical experience that our staff needs for the next conflict, and we won't have the well-trained physicians and nurses and corpsmen that we need to save lives on the battlefield next time. Thank you.
Good, Mr. Visklowski. No, when my visit to Brooke, I guess it's changed its name, but Brooke Army Center, you're pulling in a lot of the population in that neck of the woods in order to make sure that those skills are you know, they're high quality. And of course, there is the issue here of morale, and this is, you know, considering the number of those in the military today that are married, that they expect and anticipate, as they should deserve, the highest quality care for they and their families. On behalf of the committee, I want to thank our panelists for being here, and our thanks to the men and women that you represent for the superb job they do each and every day. We stand adjourned. Thank you.
Thank you, sir.